லைவ் கேட்கல. ஹலோ 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 ஹலோ
ஹலோ.
ஹலோ 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 ஓடியம் இருக்காங்க. ஹலோ 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 ஓகே ஓகே.
thank all the members because in spite of the IPL finals, you have all come for the meeting, and I should really thank all of you. And we had this Hair Society's quarterly meetings very regularly till 2010. Then we had the Hair India conference in 2010, 12 and 14. And after that, because of lockdown and all that, we couldn't continue. Now we have revived. The last meeting was on last year, December 22. This year we have the meeting today. And fortunately and very luckily, we have got the same speaker, the wonderful speaker, Diwakar Sudian, all the way from UK. And welcome, Diva. So to start with, let me invite Dr. Ravi, one of our founder members, and with a golden voice to give the invocation song and start the meeting so auspiciously. Welcome, Ravi.
Good evening. Namaskar to each and everyone, offline as well as online, right, Muruga? महेश्वरा साई नारायण महादेवा महेश्वरा साई नारायण नटनागर दुख बंजरा साई नारायण नटनागर दुख बंजरा साई नारायण महादेवा महेश्वरा साई नारायण करुणाकरा अखिलेश्वरा साई नारायण करुणाकरा अखिलेश्वरा साई नारायण अल्लाह तुम महावीर येशु साई नारायण अल्लाह तुम महावीर येशु साई नारायण हृदयेश्वरा परतीश्वरा साई नारायण हृदयेश्वरा परतीश्वरा साई नारायण महादेवा महेश्वरा साई नारायण साई नारायण साई नारायण थैंक यू
Thanks, Ravi. That was wonderful. We should thank Ravi for coming all the way from Bangalore. We started the Hair Research Society in the year 2004, just with 7 members, and fortunately all are here. Myself, Chief, Dr. Rajshekhar, Dr. Ravi, Sarveshri ma'am, and Sampath Kumar sir. So it's a very nice moment, which I can never forget again. Thanks, Ravi. Let us observe a minute of silence for, because unfortunately this month we lost one of our members, Dr. J.P. Rajkumar, a great physician. He was not only the savior of the poor, but also the physician for the who and who of the city. Let us observe a minute of silence. Thank you. Since one of our founder members, Professor Shivakumar, is not well, I request Ravi to be the chairperson for this meeting today.
I am not the chairperson, I am a co-chairperson. Good evening to all of you, and thank you very much, Dr. Morug and Chief, for calling for these meetings, and because I am the family member of this society, which started about 10 years back and grown up to the level of excellency. And Chennai has always been my second home, and I would like to come whenever get an opportunity to come to Chennai. And today, as he mentioning about IPL matches are going on, so I am sitting here just like an impact player, the impact player, but I don't know, because of Dr. Shivakumar, really we are missing him, and the impact which he gives in any meetings is 100%. He is always prepared 1 month before. As any meeting, is a very excellent human being, and really missing him today. And to carry forward today's proceedings, and we have excellent topics have been selected, and which has been very useful in day-to-day practice. And one of them is game changer, that is what we call JAK inhibitors, Janus kinase inhibitors. That's one of the pathway which is responsible for so many dermatological conditions. And we have been using it in last many years, and some of them are tofacitinib and baricitinib. In the era of NIPS and MAPS, I think Murugs, we should know a little bit of Sanskrit to, to pronounce these molecules. There are so many biologics, NIPS and MAPS have come in field of malignancy, dermatology, and so many other autoimmune conditions. So without wasting, we'll know what is the update on JAK inhibitors. I would like to invite Dr. Paul Devakaran Esudian, consultant dermatologist of UK, I call him, and son of our chief. And he has been excellent throughout whenever he comes and delivers his lectures. Over to you, Devaka.
Everybody hear me here? Thanks, Murugs, for inviting me to talk here again. And thanks for everyone to attend in spite of the IPL finals today. Thanks also for the introduction.
It's not yet started.
Oh dear. Yeah, that's good. So, good evening everyone. Today's topic is game changers, that's JAK inhibitors for alopecia areata. So I've been hearing a lot about JAK kinase inhibitors in the last few months and years. So I thought I should look into this particular molecule in a bit more detail, particularly in alopecia areata, because my knowledge of the basic sciences was quite poor, particularly for this particular new agent. So what I'll be trying to do in the next 10 to 15 minutes is explain to you how JAK kinase inhibitors work and how the alopecia areata pathogenesis is actually unique, and therefore JAK inhibitors play a specific role in trying to control this condition. So I've called it a game changer because till now we don't have that great a treatment for alopecia areata. We can control it. We can use various oral and topical agents, but none have been as effective as JAK inhibitors. So to continue with our theme, just like Shubman Gill has been a game changer in the IPL, I guess our new molecule is going to be a game changer for us. So I'll be splitting my talk into three parts. Let's look at the pathogenesis of alopecia areata first. Then we'll look at the mechanism of action of JAK inhibitors. And then finally look specifically of the practicalities. How do we use it? What dose do we use? What side effects there are? Because this is what we will need to know as practicing physicians. Let's look at the pathogenesis of alopecia areata first. It's quite a unique type of pathogenesis. We all know it's autoimmune, so it's our own immune system attacking our own hair follicles. But there are some specificities in it which we need to understand first. There are other possible etiological factors too. There is a genetic factor. So if you look at alopecia areata, generally there will be a family history in a majority of those who've had it, meaning more than 50%. Autoimmunity, we already know there are these autoantibodies, particularly T lymphocytes against the hair follicles. And there are environmental factors too, things like stress, viruses, certain medications that can trigger it off. But what we need to know specifically is this immune privilege. So there are immune privilege areas in the body, of which hairs and skin are part of it. That's the reason why we have no immunity against normal hair and normal skin. And the reason that occurs is because of two factors. One is there is a very low MHC expression. There's a very low MHC expression, which is major histocompatibility complex expression, and there are suppressed natural cells, natural killer cells, and I'll show it to you in the next slide. We need immune privilege. We need our immune system to protect us from infection and cancers, but we don't want our immune system to attack our own cells. So that's why immune privilege is so important. It maintains normal tissue function, but it also prevents external things and cancers from occurring. So let's look at what happens in immune privilege. Now, if you look in the left, where there's healthy hair follicles, you can see that there is decreased MHC expression below the isthmus. And if you look at the cytokines, there is no immune cells there. There's no CD lymphocytes, no CD8 lymphocytes, and there's increase in interleukin 10. And I'll tell you the significance of this later on. Interleukin 10 actually is a protective interleukin. It makes sure that there is no autoimmunity. So it is actually quite important. But see what happens in alopecia areata on the right. Firstly, there's increased MHC expression, which means there are more T lymphocytes coming into the hair follicles. So if you look on the right, you can see not increased natural killer cells, and that damages the follicular epithelium, and there's plenty of T cell infiltration there. So this is typically what happens in alopecia areata. On the left-hand side, you can see a normal anagen hair follicle, and on the right-hand side, this is what we see as the swarm of bees appearance. So what is the swarm of bee appearance? It is full of T lymphocytes, dendritic cells, plasma cells, and mast cells. And all of these are activated because the immune privileges come down. And because the immune privileges come down, increased activation, and therefore autoantibodies are formed. Now that we know roughly what's going on in the hair follicles, let's look at how JAK inhibitors work, because there is an interaction between these two. What first is JAK inhibitors? You actually have to call it the JAK-STAT pathway. It's not just the JAK, it's the STAT molecule with it, and they're all proteins sitting on the cell receptors. What they do is they form a communication between the outside of the cell and the cell nucleus. And this communication involves Janus kinase, which is JAK, and STAT, which is signal transducer and activation of transcriptase proteins. And I'll show you these in an image. If you look at this image, the pink is the receptor, and along with the receptor, you have the JAK kinase, and attached to the JAK kinase, you have the STAT protein. In normal cells, this is what happens. There is something from outside the cells which are called ligands, and they can be viruses, interleukins, whatever. They come and attach themselves to the receptor. They then activate the JAK molecule that phosphorylates. That then activates the STAT molecule, which phosphorylates. That comes to the nucleus, and then the nucleus produces proteins which give signals to the cells as to what to do next. So this is normal. Now this is what happens in JAK kinase inhibitors if you use them. On the left, you can see the normal pathway. And remember, this pathway is overexpressed in alopecia areata. That's the problem. So on the right-hand side, you can see that the JAK molecule actually binds with the receptors and prevents the STAT molecules from being phosphorylated. It therefore prevents all the inflammatory cascade below that. So you may wonder how this is related to the hair follicle. So let's look at the next slide, but before that I'll have to tell you where each receptor is. There are 4 receptors. There's JAK1, 2, 3, and there's something called TYK2, tyrosine kinase 2 receptors. All of them are important. If you look at JAK1, they're mostly in inflammatory disorders, so rheumatoid arthritis, maybe even a bit of psoriasis. JAK2 is mostly for hematopoiesis, so all the myeloproliferative disorders. JAK3 is mainly the lymphoid lineage, and then the TYK2, it can be associated with many of these other functions. The reason you need to know this is, depending on which JAK kinase you use, the side effect profile will actually be understood. For example, if you have a JAK2 inhibitor, you will get neutropenia because it's going to attack the hematopoietic cells. If you have a JAK1 inhibitor, it's going to be a very broad range of anti-inflammatory cells. So what we want with alopecia areata is probably JAK3 inhibitors because they are more specific lymphoid cells, and that's the cell we saw in the hair follicle. That's theory though. In practice, if you look at it, most of them are a combination of all of it. It's not just JAK3, it'll be JAK1, JAK2, JAK3, even TYK2 inhibitors. So knowing this is important because you may know what the side effect profile is, but using this to actually target which JAK inhibitor you want probably isn't, it's more an academic exercise. So this is what happens at the level of the hair follicle. Now if you look at it on the right hand side, at the bottom you have the T lymphocyte, and at the top you have the follicular epithelial cell. Normally in alopecia areata, all of these are overexpressed. Because it's overexpressed, you can see that the nucleus starts producing loads of interferons, particularly interleukin 15. When that interleukin 15 goes back to the T lymphocyte, it makes it produce even more cells. So it's a vicious cycle. It produces more and more inflammatory cells. And what we want to do is block this. And that's why these JAK inhibitors come in. So if you look down there, JAK1 and JAK3 is what's found in the T lymphocyte. So you have tofacitinib, which blocks JAK1 and JAK3, and you have ruxolitinib and baricitinib, which blocks JAK1. And then if you go to the follicular epithelial cell, you have JAK1 and JAK2, and that's where baricitinib, ruxolitinib, and tofacitinib works. So if you know roughly what's happening at the level of the hair follicle, you can understand how these JAK inhibitors work. So let's look at next the practicalities of which JAK inhibitors are used, what the dosage is, and what the side effect is. The one which has the most evidence is baricitinib. They've done the biggest study. It's called the BRAVE study, nearly 1,200 patients. Ruxolitinib is probably the next new one on the block, but tofacitinib is the one which we have most experience with. So we'll look at these three in more detail. Tofacitinib, as I said, it's the oldest one, first reported in 2014. And remember, most of the JAKs were actually used for something else. Here, for example, they were using it for psoriasis, but they found that it actually worked for alopecia areata as well. And this works against JAK1 and JAK3. And the largest series was 90 patients and fairly good results. About 65 responded, so about a 75% response rate, of which 13 were full responders, which means they had complete hair growth, and 37 were intermediate responders, which means they responded about 50% of hair growth. Baricitinib inhibits 1 and 2, JAK1 and 2, first reported in 2015, and this is the only one which has 2 RCTs, both published just last year in the New England Journal of Medicine. Huge studies. One BRAVE AA1 was nearly 650 patients, and BRAVE AA2 was 540 patients, so more than 1,200 patients. But if you look at the final result, it's about a 40% improvement. So it's not as great as anti-psoriasis treatment. So it's reasonably good, but the SALT score was very good, 80% improvement of each person. And this is the BRAVE 1 and 2 studies, and you can see on the left-hand side that this is the proportion of patients who have a SALT score of less than 20, which means they had 80% regrowth. And if you look at baricitinib at 4 milligrams, about 41% responded. If you have the 2 milligrams, it's only about 21%. With the BRAVE 2 study as well, you can see that about 36% responded. You have to wait for quite a long time. If you look at the study, they did it for 36 weeks, but it continued to improve even after that. So up to a year you may have to wait before you have an improvement. Ruxolitinib is another new agent which has come on. This is a JAK1 and JAK2 inhibitor, and it has some effect on TYK2 as well, which is the fourth receptor. Quite a small study, only 12 patients, but 9 responded, and very impressive, 92% regrowth of all hairs. The newer agents also have excellent evidence. This is a new study, Allegro study, And they use two receptors, two JAK inhibitors, ritlecitinib, which is a JAK3 inhibitor, and brepocitinib, which is JAK1 and TYK2 inhibitors. So let's look at the study. This was an American Academy of Dermatology publication. And if you look at the SALT score again, if you want a 90% improvement with both drugs, it was about 25 to 35%. But if you look at only a 30% improvement, then you get closer to 50 to 65%. So you do get improvement, but only a mild improvement in a majority. If you want that full hair growth, you're probably going to get it only in about 30%, maximum 40% of patients. And this is even with the latest JAK inhibitors. What investigations do we do? The usual ones: full blood count, Useny's, kidney tests. And remember, if you know that they are a JAK2 inhibitor, you have to be more careful looking at the full blood count, because neutropenia is very possible there. You have to do a viral hepatitis screen, because all of these can result in increase in chance of infection. TB screen is also quite important, and we do it in the UK as well before we started, and it can increase LDL cholesterol, so you have to do a lipid profile before starting. Dosage wise, each JAK inhibitor is slightly different. Tofacitinib is between 10 and 20 milligrams. The study they did with baricitinib was 2 milligrams and 4 milligrams, but most effective was with the 4 milligram dose. And then ruxolitinib has been used at 20 milligrams twice a day. With the newer agent, brepocitinib, was 60 milligrams for 4 weeks and then 30 milligrams for 20 weeks. So you can see that all of them are used for at least 6 months. And then finally, ritlecitinib, 200 milligrams for 4 weeks and then 50 milligrams for another 20 weeks. If you look at all studies, generally they use it for at least 6 months. And if they're changing the dosage, they change the dose after a minimum of 4 months. So if you're starting, for example, baricitinib at 2 milligrams, you use it for at least 4 to 6 months, and then you go to 4 milligrams, another 4 to 6 months. So you take 1 year to exhaust one drug if you want to use it properly. So really, really long periods of time. And remember, even after this 1 year, only 30 to 40% will have a 90% improvement. All the others will have a 50% improvement, but not a 100% improvement. So you have to be a bit realistic even with our patients. One thing we shouldn't tell them is, oh, don't worry, you'll get all your hair back. It's probably not going to happen. They will get a majority of their hair back, but that's not going to be the same as complete regrowth. Quite a lot of minor side effects. You know, you can get abdominal symptoms, but by far that's the commonest, a bit of nausea, tummy upset. There is an increase of urinary tract infection and respiratory tract infections as well. So you do have to warn patients. Probably they do have to take more care, maybe wear masks and other things if they're going to high risk areas. There is this new evidence that it causes folliculitis and acne. In fact, when I went to the American Academy recently, they call it JAKne. It's not acne, it's JAKne, because it's so common to get folliculitis and acne with that. With JAK inhibitors. And then the raised LDL cholesterol we've already discussed about. That's why we have to baseline lipids and repeat it every 4 months. Some slightly more serious side effects, zoster recurrence does occur. So in some institutions, particularly if they know they're going to use the JAK inhibitor for quite prolonged periods, they actually give them the zoster vaccine. Before they start, they just give them the zoster vaccine. DVTs, thrombosis seems to be commoner too. And then TB reactivation, that's probably something which in India is going to be quite tricky. You have to be quite careful to screen people. And then liver damage as well. These are rare, but they are serious side effects. And most recently, there was this warning which came as it's like a black box warning. And the study they used is they compared the side effects of TNF antagonists and JAK inhibitors. And what they found was that if you compare the two major groups, TNF antagonists and JAK inhibitors, you have 1.6 times more likely to get a major adverse cardiovascular event. So this is not against baseline, it's against a TNF antagonist. Similarly, malignancy was 1.3 times more likely to happen if you use it again, comparing it to a TNF antagonist. These absolute numbers are still very low, so I wouldn't be too worried about it yet. We don't have long-term data from dermatological literature, but it doesn't look frightening enough to not give it to our patients. Because if you look at it, TNF antagonists have been there for 20 years, and there's still no major risks about cancers and major adverse cardiovascular events yet. So if you compare with TNF antagonists, it's slightly higher, but then TNF antagonists itself don't cause it that commonly. So overall, you have to be aware of it, but it's not that worrying that we don't give it to our patients. Just a word of caution. I told you about that interleukin 10, which is there in healthy people. In fact, it's one of the interleukins which protects us and keeps immune privilege. The problem with JAK inhibitors is it inhibits interleukin 10 as well. So this article, which was published in the Lancet, tells us to be careful. What could happen to the hair follicles if you actually take away interleukin 10? It may actually make the autoimmune process worse. So in effect, if you start using JAK inhibitors for alopecia areata, you probably have to carry on for life, because this is going to be inhibited too. So therefore, this immunological phenomenon is going to get worse and worse and worse. So you really can't stop using a JAK inhibitor. So this is a word of caution in that Lancet article. So the take-home points which I want to convey really are that JAK inhibitors are effective, they do work, but probably be a bit realistic in how effective they are. It's not like psoriasis where we have excellent drugs. We can tell our patient, yeah, I can clear you. We can't quite say that with alopecia areata yet with JAK inhibitors. We can give them most of their hair back, but not all their hair. The response rate, as I said, is, if you look at an average, it's about 60%. And this is only more than 50% regrowth, not 100%. Knowing the potential side effects is quite helpful to make a good risk-benefit ratio. So as long as we explain to our patients, these are the risks. If you want me to give it to you, I will, but look out for these potential side effects. And as long as you have no problems, we can try it and give it a go. And you have to use it for a period of at least 6 to 12 months. And I'm sure patients will be bringing you, many patients bring paper cuttings like this, New York Times telling how wonderful this drug is. So hopefully next time the patients bring this to you, we'll have a rough idea of how exactly JAK inhibitors work and what we can tell our patients. Thank you. Any questions?
Thank you, Dr. Divakar. I think let's go ahead with the trichological case scenarios. After that, we'll have a question and answer session.
So I've got 4 cases, all of them localized to the scalp. So we'll see how many of you get all 4 cases right. My first patient was a 59-year-old lady. I saw her just before lockdown was starting. So February 2020, in fact, she was going to New York. So she said, I want to be clear. And when she came to my clinic, she had quite a lot of hair loss and a rash on her face. It was treated as eczema. I think they gave her topical Humavate to try. So I'll show you some pictures. You can ask me any questions, and then I'll tell you what happened. So that was her hair. You can clearly see that there was significant hair thinning. All of this is new. All of this happened in the last 4 months. And that's a closer view. Any differential diagnosis you can offer? She has a facial rash as well, which I'll be showing you. Next. ANA could be positive. Yeah, so you're thinking about? DLE? Yeah, possible. Anything else? It doesn't have those discoid areas. You can clearly see some atrophy and some telangiectasia. I'll show you her. Subacutally is possible. So that's her face. You can clearly see that there's periorbital edema, erythema. Pardon me? Yes. Nobody picked up that she had muscle weakness. So when I asked her, are you able to get up and are you able to lift your hand? She said no. So I was really worried. She was going to the US, a week later. So I started on high dose steroids. I said, come back safe. Till then you have to have the steroids. So I gave her 60 milligrams of pred, sent her and told her to come back as soon as possible. And that was her hands. You can clearly see Gottron's papules there. And it was dermatomyositis. Her CAK was quite raised when I first saw her. Did a skin biopsy when she got back. Her CK had come down by the time she returned. We do the TIF1 antibody. Why is that? What does TIF1 antibody indicate? That's what tells you if you have an underlying neoplasm or not. So if you have TIF1 positivity, you have to be quite careful not to immunosuppress them. We did a whole body CT scan because anybody over the age of 40, we have to make sure they have no underlying cancers. Did a whole body CT scan, that was normal. And there was some improvement of her rash and her hair, but her muscle weakness didn't really go. So I sent her to the rheumatologist. They started on methotrexate, but unfortunately it worked well. All her skin got better, her muscle got better, but her LFTs started going up. So even though her hair and skin was okay, we had to stop the methotrexate, unfortunately. And that's with methotrexate. As we were closing, you can clearly see that there's some regrowth on her hair, and the dorsal hands looked a little bit better. As she came off methotrexate, her rash slowly started to come back again. So I tried various things. Started hydroxychloroquine, gave that for about 3 or 4 months, didn't work. So I added in mepicrin, again no benefit. I was now stuck. I didn't know what to do next. So it's nearly about 18 months now from the time I first saw her. So any ideas what we could do next? What other treatment we can give? Yes, that's what we had to give. So we gave her IVIG because we're still a bit worried about underlying neoplasms. And actually IVIG is an excellent treatment for dermatomyositis. And complete hair growth. She's had 6 cycles till now. And really good hair growth. And even our dorsal hands seem a lot better. So from my reading of IVIG, it improves the short-term prognosis, but relapses are possible. So really you do have to continue with for quite a good period of time. You can maintain this disease remission for longer duration than conventional treatment, but generally you may need to add something else on. So I've just kept her on IVIG because that's the only treatment which has worked for her, and she seems quite happy. So if it remains the same, I'm going to just increase the duration of time between each IVIG infusion. That's my plan. So she's had 6 infusions till now. So this unfortunate gentleman, 61 years old, came. He said he's had this lesion on the back of his scalp for a very long time, since he was a child. Usually asymptomatic, but suddenly in the last 8 weeks, it's become really painful, and the top of the scalp, which was sort of relatively flat, has become more raised. So that's the lesion. Anybody want to have a guess what this could be? That area on the top is where he's noticed something new. Pardon me? Lymphangioma. It felt quite firm. All of that looked almost, like a nevus, connective tissue nevus, sebaceous. Yeah, it looked like some connective tissue nevus, sebaceous nevus, connective tissue nevus. Why do you think that's become painful on the top? Pardon me? Yeah, my main worry was that it was turning malignant because he was also getting headaches. I didn't want to do a biopsy there, so I did a biopsy lower down, which confirmed that it is a connective tissue nevus. But after that, he had CT scans, MRI scans, which clearly showed that there was a proliferative tumor there, which had actually eroded the cranium and it was going into the brain. And that was that lump. Can you see that lump on the top? That was the bit. He couldn't even rest his scalp there. So unfortunately, this chap developed a peripheral nerve sheath tumor from a connected tissue nevus. He was dead in 6 months. So it just got worse and worse. We couldn't do anything. We sent him to the neuro center. They tried doing radiotherapy. Nothing helped. So unfortunately, we had to just give him palliative treatment towards the end. He really suffered a lot. This was another interesting patient. Came with this cutaneous horn. He said it's been there for about 3 or 4 months. You can see it's a fair size. Closer view there. What would you do? What would you do with the cutaneous horn? Biopsy it, yeah. You just got to remove it. So I curated it. That was it. And what do you think the differential diagnosis could be? Yeah, that's the main thing, isn't it? Huge cutaneous horn. You think, could there be a squame there, especially white skin? But there was nothing. Only inflammatory tissue. No malignancy in the base. So I was a bit surprised. I was really worried about him. I thought it could be a squame. So I called him back 6 weeks later, and this is the picture. Exactly the same again. So I curated it again. So what do you think? Even this biopsy didn't show only inflammatory tissue, nothing else. Not a what? No viral lesions. He's not applying anything on the scalp. No fungus, nothing. So I gave him a treatment here because I had a clinical diagnosis. And when I saw him back, it was a lot better. That was him after 4 months. So you see that, I mean, even that wouldn't have been there if he had used the treatment properly. So what do you think this is? Pityriasis amiantaceae? Yeah, you're going the right way. You're looking at something inflammatory, which is right. I think I showed you a picture last time as well. So this is a condition probably which you guys don't see here that often. This is called erosive pustular dermatoses. So what happens is there's probably a little bit of sun damage, probably a little bit of bacterial infection, and then there's a vicious reaction against it, immunological reaction, and you get this huge crust full of pus, and that pus coagulates to form these cutaneous horns. So what you do is once you've removed it, once you've curated it out, you put a potent topical steroid with an antibiotic. So I gave him Dermware NN and Cinelar C. That's why it didn't recur again. So always think of inflammatory things as well. It looks like a skin cancer, but it isn't. And then my final case. So again, this lady I've been treating for a long time. She's got horrendous hidradenitis. I started off with the usual antibiotics, gave her rifampicin and clindamycin, retinoids. Nothing touched her. Really significant, and quite a thin lady as well. Oral retinoids. Gave her adalimumab. That didn't work either. And then finally I had to give her infliximab. Now infliximab we usually give in our outpatient clinic. They come every 6 to 8 weeks and they get the infusion. And I didn't see her for a few months because she said, oh, hidradenitis is well settled. And then suddenly they called me from the ward and said, oh, this lady wants to see you because she's got something she's not happy about. And that's what she had. So what do you think? Psoriasis? Any particular reason? Yes. So this is what we call paradoxical psoriasis. It's a TNF antagonist induced psoriasis form dermatoses. So what do we do next? She's still got very bad HS. Like? What can you give? You can't give a TNF antagonist, but that's IL-17 is right. Which one? Yeah. We gave a secukinumab and complete hair regrowth, because secukinumab, there are some reports of it working for hidradenitis as well. So again, I think I did a talk on biological triggered psoriasis. If you want to see it on YouTube, you can. So that explains the mechanism as to why it occurs and why some people get it and how you can treat it. Thank you. Any questions from? Yes, I should have mentioned that. From my reading, for alopecia areata, there doesn't seem to be a great amount of evidence for topical JAKs. In fact, I should have told in the first slide that I was concentrating only on oral JAKs, simply because topical JAKs just don't seem to have cut it for alopecia areata. It seems to work very well for vitiligo, particularly ruxolitinib. I think that will be a game changer for vitiligo. But for alopecia areata, it probably doesn't, simply because the inflammatory reaction is quite deep in the hair follicle. So for a topical agent to penetrate deep enough to reach the depth of the hair follicle and cause these changes, it hasn't shown to be effective yet. Age, I don't think age is a big criterion. It's been licensed for above 18, so you can use it any age above 18. I have only 2 or 3 patients on it, and one of them is a 20-year-old girl. So she seems to be doing very well. I don't think there's that much data for children yet, so I would hold off till above the age of 18. Most of them are youngsters, isn't it? Alopecia areata, it's devastating for particularly young women to lose their hair. So I would give it to any young lady who comes to me with this condition. DVT, yes.
D-dimer test, basically?
Not routinely. Usually, most of these are features you explain to the patient and tell them the potential symptoms they could get. So for example, if they get a swollen leg or they're getting pain when walking. So you tell them, listen, look out for these signs, because if these signs are there, you may have a thrombosis in your veins. So as long as you inform them and they know what to look out for, then if they come with those symptoms, then you do a D-dimer. You can't be doing D-dimers routinely because it's rare.
In obese patient, is it mandatory to do?
Nothing is mandatory for DVT screening in JAK. For JAK, it's those 4 investigations I showed you.
What are the percentage of
I don't know the exact percentage, but these are incredibly low numbers. All these serious side effects, they're very, very low numbers, all below 1%. The common ones are between 1 and 10%. Everything else is way below 1%. In fact, it's probably 1 in 1,000, 1 in 10,000. It's as low as that.
Okay. In children, alopecia areata, can we start tafasitamab?
Well, again, above 18 I would, but I'd be still a bit careful about very young children. I think methotrexate, the one I use most commonly for my pediatric patients is methotrexate with prednisolone. And there was actually a very good paper last year which compared JAK inhibitors with low-dose methotrexate with prednisolone, and they had the same effectiveness. So most of my patients are on 10-15 milligrams of methotrexate and 5-10 milligrams of pred. They'll be on both. But that's an excellent combination which is as effective as JAK inhibitors. It will give you a 60% response rate.
Okay. Sir, in case of IGRA positive, quantiferon TB gold assay positive.
Sorry, I didn't get your...
Quantiferon TB gold.
Quantiferon gold test, yeah.
See, out of 10 patients, I find 5 patients are found to be IGRA positive. Okay, in that case, I had discussed with pulmonologist. He said you can start isoniazid prophylaxis. Simultaneously, you can start, or otherwise, after completing that 1.5 month course, you can start tafasitamab. Is it safe, or is there any percentage of reactivation of TB? Because we are going to almost for 1 year or 2 years, we have to continue, right?
Yeah, I wouldn't be very happy to just give INH monotherapy. In the UK, if we find anyone with a positive result, which is very rare, we send them to the chest physicians and they give the full whack. First 3 months, full multi-dose chemotherapy. And they try to clear the MTB as much as possible. Then they may have a prophylactic phase after that when they give INH monotherapy. But I would be very uncomfortable giving JAK inhibitors without full treatment of TB at least for 3 months.
Okay. Sir, most of the side effects of tafasitamab can be neutralized with apremilast. Can we combine together in case of almost...
I don't know. I don't think there are that many studies looking at combination with JAK inhibitors. They've always been used on their own, particularly all the studies. They use it as monotherapy. So I don't know much about whether you can combine it with another agent. I'd be a bit careful.
Is there any contraindication to it? There is any contraindication to it?
I don't think there's any contraindication simply because nobody's tried it yet.
Okay.
Yeah.
Okay.
And does it worth using intralesional steroids simultaneously with the JAK inhibitors?
Yeah, I mean, that you can do. You can try using an oral JAK with topical agents. So any of your topical agents, or you can use other oral agents like minoxidil to increase the hair growth. But I wouldn't use another immunosuppressant which is oral. I would use other topical agents and then other agents like irons, thyroid function test, minoxidil, so intralesional, those are fine.
So another clinical scenario is what is happening also used in atopic dermatitis. Nowadays, I've seen many people are using tofacitinib, even baricitinib. So the clinical correlation, as you said, it's around 40 to 60% improvement. The patient sometimes comes with the IgE level.
With the
IgE level.
Yeah.
Very high IgE level before you start the JAK inhibitors. And after 6 months, the IgE level will not dramatically come down. It may come down a little bit. So how will you convince them?
How do you convince
Patient.
For what? For
They are always worried about IgE. They look at the IgE level.
No, I mean, IgE is just a lab thing, isn't it? I mean, in the UK, we hardly do IgE levels simply because of this reason. You shouldn't focus on a lab investigation. You ask the patient, how do you feel? If your eczema is better, why do you worry about your IgE level? So there generally I think you investigate more here than we do there. There we do more clinical medicine. Here you do a lot of extra tests, which we probably don't do.
So it has no clinical correlation.
It has no clinical correlation at all, no.
So any more questions?
So thank you for the informative talk, sir. I have a few questions for you. So after starting the drug, how soon do you start seeing a response in the patient? Or till what time should we ask the patient to be patient?
My experience is that you have to use it for at least 3 to 4 months. In fact, I don't schedule a follow-up visit for at least 3 months. I tell them come back after 3 months because I know that nothing would have happened for the first few weeks. So minimum 3 months. If they start seeing an improvement and they're happy with it, we carry on with that dose, or you increase it to the higher dose and use that for 3 to 6 months. I try at least 6 to 12 months of any treatment.
So during the 3 months, do they come up with the follow-up investigations only at that point of time?
Yes.
3 months.
Yeah.
When do you start tapering it? Some patient has reached the adequate response. How do you taper the patient?
I'm afraid that's not known yet, and from my reading, it's very hard to even taper or stop it, because I've shown you in that last slide that interleukin 10. Will we actually be able to remove it completely? I don't know. I don't know whether we can actually get rid of it after we've started it. We may have to keep with this lifelong, really, for some patients.
I think we have few postgraduates, I think, interesting questions. Still you can ask.
Okay.
I haven't had any of the major side effects. Most of the common side effects I've seen, most of my patients, remember, are eczema patients. I've got about 25 to 30 patients, but they are mostly for eczema. Fortunately, 2 of them also had alopecia areata, so I can see that they're responding to that too. In fact, both of my patients are on upadacitinib, and they are responding, their alopecia areata is actually responding. So the common side effect I see is this acne, folliculitis. Some of them had a little bit of nausea, but that settled, so I've not seen any of the major side effects yet. Pregnancy, is it? I don't know the answer, but I would probably use at least 3 to 6 months, yeah. Just like any other immunomodulator.
So I have one question. We are screening for tuberculosis before starting to first-in, right?
Yeah.
So after we start, how often do we screen again for it, because he can develop anytime?
In the UK, we don't screen again, but the guidelines suggest that if you're in a high-risk area, you do it on a yearly basis.
So
Yearly basis.
And one more point I want to just convey is that tofacitinib in pediatrics has been they are using, rheumatologists are using for
Yes.
pediatrics.
I think they are using it for other conditions, as you said, psoriasis and rheumatoid arthritis, but not for alopecia areata yet. For alopecia areata, if I'm going to start it specifically for alopecia areata, the only drug approved in Europe is baricitinib. So at present, that's the only one I can prescribe. But as I said, I've got these other patients who have eczema, so I've given them upadacitinib, which is actually none of these, and they seem to be responding too. Combine what with what, sorry? No, I'm afraid we don't have that much, I don't have much knowledge on lasers, so...
You said the chance of malignancy is more.
It probably could work, yeah.
So
But
the combination, we need to be very cautious or not.
I don't think you have to be cautious because there are different mechanisms, but I don't have that much knowledge of lasers.
Okay.
If there are no questions, thank you, Dr. Divakar, for excellent talk and very good interaction. We normally don't find it such cases in India, so it was very interesting, and you brought those 4 cases scenario, very interesting. So we do have to look into those areas also. So thank you once again, and I request Dr. Sampath Kumar to hand over the book, please. I think we are not moving out of JAK inhibitor still. We'll continue to have this discussion. Now I invite Dr. G. Ravichandran. He doesn't require introduction, and is our regular member of
Of course, I'm not going to discuss about all the facts. I think Diva has given us a very good view about the basic mechanisms and what is JAK pathway and JAK-STAT pathway. Alopecia areata is an autoimmune recurrent non-scarring type of hair loss that can affect any hair-bearing area and can manifest in many different patterns. We all know that as students we have seen quite a number of patients with all kind of types of alopecia areata. It's of course very difficult for a young boy or a girl or a man to get this and have so much of social impact. I saw this patient in November 2022. He was referred to me by my student from Tanjavur. He had severe alopecia areata involving most of the body surfaces including the scalp. He has taken all kind of treatments including topical steroids, intralesional steroids, systemic steroids, unto the contact sensitizer, the DNCB. Then I thought probably we need to work for a newer option in the form of tofacitinib. I did a basic workup as Dr. Diva was telling. Base involves CBC, liver enzymes and lipid profile is very important. And TB test and gold quantiferon can be performed. And of course viral hepatitis C has to be checked. I started him on tofacitinib 5 mg BD for a period of 6 months. And periodic review every month he used to come because he started showing some good results. And I called him to just find out what are the side effects or probably what type of results we are going to. This is my first second case report. So we look for all the side effects of respiratory infections, hypertension and weight gain. Weight gain is also been reported in the long terms, probably in higher doses of 10 to 20 milligram of tofacitinib. I would like to show you the results. This is how we started. After 1 month, small fine hairs. After 5 months and 6 months, I can see a lot of hairs coming onto the beard, body areas as well as the scalp. It's very puzzle. I want to pose this question to Professor Divakar and Murugasundaram. He never had any kind of a pigmented hair. All the hairs were white. But he's still maintaining this kind of colored hair on these areas. I have no explanation for that. Probably it's a real challenge. I do not know. We'll take up this for the discussion when we answer the questions. This patient, this was my first patient on tofacitinib from the original molecule from Pfizer. He's a doctor's nephew who's a college student of 19 years, stopped going to the college for 1 year from 18 to 19. He had severe alopecia totalis and again tried all kind of medication available, and finally I started this new treatment from Pfizer original molecule. It was very, very expensive. He almost paid 25,000 per month at that time in August 2020. He continued for maybe 9 months to 1 year. Regular follow-up he came, and the COVID came, and I told him to stop tofacitinib during the early COVID period, phase type 1. So you can see the very good results and good hair growth in all the areas. And he came to me some 6 months ago. We stopped tofacitinib. He started losing the hair. More or less around 50 to 60% have lost its growth. So we need to discuss about how long, why refractory, when do you start some other molecule, or probably is it to restart again with a higher dosage? We do not know the answer. So avoid tofa. Women planning pregnancy or lactation, live vaccinations. Nowadays vaccination is being generally given. Please avoid. You can give, as Deva said, herpes zoster vaccine, which is not a live vaccine, and concomitant use of the inhibitors of the liver enzymes. And caution, above 50 years, history of serious infections, comorbid state, obesity is one of the factors which can result in hypercoagulable states, venous thromboembolism, hormonal therapy in women, smoking, and Deva was telling about serious cardiovascular risk. It's very important that we need to be very careful in patients who have a high risk factors, and malignancy of course. Monitor regular CBC liver enzymes at every 4th weeks, lipid profile at 8 to 12 weeks, monitor signs for infections including venous thromboembolism, appropriate malignancy screening is, of course, Diva, everything has, he summed up everything at the. I would like to put some questions for the Professor Patrick and Professor Divakar Isudayan. What is the reason for the regrowth of white hairs in the case number 1? In case 2, recurrence of alopecia 2 years after withdrawal of TOFA, other whether to initiate oral steroids. Case 3, what could be the reason for no response even after 3 months? I think I forgot to give you the other. Actually, I had one more picture. Total alopecia totalis, 4 months of TOFA, not even a single hair regrowth. So that is the reason that, I don't know whether it got missed out in the PowerPoint. So that is the reason. And of course, this is, I think, Diva must have seen this. It's a wonderful, recently published. They compared tofacitinib, all the newer molecules, which Ravi was telling, it's Sanskrit words, we are not able to even pronounce this names of these latest drugs. So this is recently come. I think it's a wonderful article for the postgraduates to read, and then probably we'll know that probably in the long study, we'll have a good answer for these cases. Thank you so much for giving me an opportunity, Divakar. Sir.
Thank you, sir. As usual, it was an excellent presentation. Sir is an excellent dermatosurgeon, my first teacher, and for most of us, the first teacher in dermatosurgery. And the way he does vitiligo surgery is like magic, you can see. And if I can answer the first question, like why do you get only white hairs in alopecia areata? The regrowing hairs are all white. Because alopecia areata specifically targets anagen 1, 2 or 3. You have this anagen 1 to 6. Anagen 1 and 2 is specifically targeted in alopecia areata. And the anagen 1 and 2 are coupled with the pigmentation of the hair follicle. So since the pigmentary cycle is affected of all the anagen 6 cycles, the first 2 are the pigmentary cycles. So that is when the hair follicle melanocytes impart pigment into the hair. So that is why the regrowing hairs are always white. And that is why you get this sparing of white hairs in alopecia areata.
Yeah, that's of course known, so Murugu's favorite answer for this white hairs in alopecia areata. But what shall I continue the same in TOFA for another 6 months and see whether the pigments depigments the hair?
Yes, usually in any treatment of alopecia areata, initially the regrowth is white hairs, and gradually it repigments. So gradually the immune dominance is reduced in the alopecia around the hair bulb.
Okay. Does it require any biopsy, hair biopsy? No need.
I don't think so. If you have doubts in the diagnosis, you can do trichoscopy and confirm.
Thank you.
I would like to ask Chief, because the role of Methotrexate, maybe in the final remarks, if the role of Methotrexate along with steroids, the role of Methotrexate along with steroids for the extensive alopecia areata, scalp only. I had a case of a lady who had extensive, not totalize, but started with steroids, taper it slowly, then simultaneously started with Methotrexate about 10 to 15 milligrams. She responded very well within a matter of 6 months. So still I think the role of Methotrexate in alopecia areata is quite effective, and but tofacitinib I have started in one patient along with intralesional. She was so worried about her hair loss, and she is responding very well. As Divakar was mentioning, it can be given along with the intralesional or oral steroids with tofacitinib. But another case is atopic dermatitis, which is I started him on tofacitinib. Not much response, as you mentioned. I think around 40% response. Now they want to shift over to the baricitinib. Whether it is worth or not, I am not sure. And now I have not restarted the baricitinib, but I am maintaining with the topical emollients and steroids and tacrolimus. So he's doing really good. He's a college student. He's doing very well with topical treatment. Now I request Dr. Sarveshwari to hand over the bouquet to Dr. Ravish Chandran. Now we have come to the very interesting talk by Dr. Murugasundaram as usual. The spectrum of clinical air disorders. So we call it now season 2 and episode 2, because after gap of about 7-8 years we restarted. Now season 2, episode 2. Over to Dr. Murugasundaram.
Thanks, Ravi. Respected Chief, Diva, my teachers, all my teachers are there, and it's a great honor for me to stand in front of this august gathering. I used to do this spectrum of clinical air disorders from 2004 to 2010, and now after a gap we started again in December 22, and this is the second part of that. And of the first season we even published a book, yes, Century of Cases. Next slide. Center. The first case is two sets of identical twins with insufficient hair growth after the first tonsure. They had sparse, thin, hypopigmented hair, slightly curly, very soft hair. Both of them showed no hair shaft defects. Both of them were born to consanguineous parents. This is the first set of twins. Second set of twins. Very soft, hypopigmented, fine hairs, sparse hairs. Slide. Yeah. What is this? Any guess? Yes. Yeah, this is congenital hypotrichosis simplex. It's reported to be less than 1 in 1 lakh. It can be associated with or without woolly hair. Along with Professor Regina Betz from Germany, we identified a mutation in the P2RY5 gene. It seems like it is very common in South India. I have seen many cases, almost about 30 cases till date, and mostly from Tamil Nadu and Karnataka. And similar mutation was observed in Pakistan and Bangladesh by the same group which identified the gene. These children respond very well to topical minoxidil and oral L-cysteine. L-cysteine is now available as an oral tablet, and you can see the growth there. So the children are very happy that they can comb the hair, and it grows up to neck length. And it could be sometimes spontaneous improvement also. Even without treatment, they do very well. The hair becomes thick, it becomes pigmented, it becomes little more denser and manageable, and they don't have any embarrassment. So you can see the length of the hair, the density is quite improved. So the other twins also did very well, but only one twin came for the review. Case number 2 is a 32-year-old female patient. She presented with a diffuse hair loss, which was mimicking a early female pattern hair loss. She was grossly pale. The hair diameter diversity was not significant enough to label as female pattern hair loss. Serum ferritin was within the normal limits. So you can see you can appreciate the pallor. She has this diffuse hair loss, which was almost, at a glance when you see it, you can easily label there as female pattern hair loss. You can see the Christmas tree pattern, but this can also occur in deficiencies. The hair diameter diversity there is not that significant. Even here you see not much of hair diameter diversity. So what could be the diagnosis? And what is one important investigation that should be done? In her case, vitamin D also was very low, but vitamin D is low for all of us. Thyroid was normal. Yes, it's a malnutritional alopecia. We did the ferritin level was normal, but the CRP and serum iron level was very low. So the ferritin is always not a very reliable indicator. You can also do serum iron and CRP and complete anemia workup. Because anemia is still very common in our women, and that is the most common cause for this female pattern hair loss. And female pattern hair loss may not be pattern, always be patterned. So there is often a very big confusion between the diffuse hair loss and female pattern hair loss. So if there is a nutritional deficiency, you treat the deficiencies first, and then you consider that as female pattern hair loss if they don't respond to supplements. Case number 3 is a 30-year-old woman. She came for a dermatological consultation, but she wasn't bothered about the hair. But in fact, she liked the hairstyle that she had developed spontaneously. She was a Bengali woman. She had this hairstyle. And she was a very clean woman and very well educated. And some of the seniors may remember when we went to Australia, Dr. Ashegar took us and we saw a Fuji native, and he had similar hair. But the first time I'm seeing an Indian girl having this kind of hairstyle. What is this? This is not plica poronica. This is bird's nest hair or dreadlocks, and they're also called as Rastafarian hairstyle. They wantedly have this hairstyle. There is a group called Rastafarians. It's called bird's nest hair. Tamil nama kuruvi koodu solluvom. Dreadlocks, sudden irreversible tangling that occurs when shampooing, especially with the herbal shampoos. The electrostatic force is generated by rotary action of washing on weathered and tethered high friction hairs. It causes the hair to stick to each other and becomes something similar to the plica polonica pathogenesis, but this is a deliberately wanted hairstyle. Long, uncut, badly weathered hair, dramatic event, usually uncommon. It is different from plica polonica. There is a group called Rastafarians who connect with themselves, and they have this kind of hairstyle, and they have a lot of social media groups, and they are very happy about it. Case number 4, I present 2 women with facial hypertrichosis. That's the African hair, they style it like that. But this is normal long hair, the Asian hair, which they wantedly they do this. They use a lot of shampoos. Deliberately they create this style. 2 women with facial hypertrichosis, and they developed 3 months after taking a medicine orally for scalp hair thinning, which promptly resolved 6 weeks after stopping the drug. You can see the hair growth here on both sides. The second woman, she had very thick growth. She is a hirsute woman. She also had hirsutism. But both of them were very happy about the scalp hair growth. Yes. And it is more in people who have hirsutism already. So oral minoxidil at a dosage of 2.5 milligram per day for 3 months induces facial hypertrichosis. And this was, I had given this dosage before I listened to Diva's lecture last December 2022. He said 1.25 milligrams is the correct dosage in women. And from then on I have been using 1.25 milligrams. But it reversed quickly in both of them. After stopping this the hirsutism, the area of hair growth on the hirsute area also reduced. This woman also responded very well, and spontaneously all the hair became better. This also reduced a lot. And again I restarted them with 1.25 milligrams of minoxidil in them. Reduced a lot. So this kind of complication of oral minoxidil is very common in hirsute women. Case 5 is 3 patients with the peculiar pattern of patchy hair loss with classical trichoscopic signs. This is a pattern. So originally he developed this pattern. It was not a whole patch of hair loss with regrown hairs, and then this patch is not, it's not like that. He developed a patch like this, in this pattern, as if something is moving. You can see the trichoscopic trichogram, you can see the anagen hairs and then the dystrophic hairs. Second case in that series, this young boy had this pattern. I think they are asking to focus the slides. He's focusing on me. And the trichoscopy showed this monomorphic white dots. And the trichoscopic trichogram, you see this dystrophic hairs. As Diva said, the immune damage is in the hair bulb area, so the hair is cut off here. It becomes narrow down. You get the tapering of the hair, that is called coudability, and then the narrowed area gets cut off. You get the rat tail appearance. So this is the dystrophic hairs which are classical of alopecia areata. So even here. You can see the classical dysplastic hairs and the dystrophic hairs. You can see the thinning of the anagen hairs. That's a weak area which gets cut off. Third patient in that series, very young child who developed this pattern. This child also underwent cranial surgery, and post-operatively she developed this. There is some amount of lichenification due to constant rubbing by the child. But you can see the exclamation point hairs. And you can see the coudability here. The hair that is cut off, and that is the dystrophic hairs, the rat tail appearance. You can see the exclamation mark and exclamation point hairs, the burnt matchstick appearance, all features of trichoscopy of that particular condition. Yeah. Alopecia areata, what type of alopecia areata? Reticulate you can say, but more specifically something figuratively. It's a serpentine type of alopecia areata, as if a snake is moving, because ophis is Greek for snake. So ophiasis is the serpentine type of alopecia areata, and ophiasis need not be always marginal. Ophiasis can be over the vertex and over any part of the scalp. It need not be a marginal alopecia areata. So it's a ophiatic type of alopecia areata on the vertex. And children always keep rubbing on the alopecia areata patch, and they develop this trichotillomania. They rub it also and they remove the hair. So there is an element of trichotillomania in alopecia areata in children. So please join the Hair Research Society of India for the postgraduates and young dermatologists who have come here. You can go to the website and download the application and become a member. You will get the International Journal of Trichology, and that is available online. It's a free journal, and you can also get the printed version. And we have the WhatsApp page and Facebook page for both the society and the journal. Thank you.
Excellent case scenario, Dr. Murugh. This is Murugh spectrum, I can say. So every
Thanks,
time he comes out with a very atypical type of presentation, and excellent Indian case scenario, definitely. Thank you very much, Murugh. Any questions?
There is a female patient who was started on antiretroviral therapy. 1 year after that, she started developing alopecia patches. Her CD4 count is good. There are multiple patches, 4 to 5 patches. What would be the best modality of treatment for her?
Cryotherapy will be the best.
Cryo.
Liquid nitrogen cryotherapy, because there is no immunosuppression at all in cryotherapy. And localized cryotherapy is also a kind of an immunomodulating therapy. It's also a sensitization therapy. So cryo is the best. And your patients respond very well.
Thank you, sir.
Thank you, Murugh. Now we have come to the presidential note by our chief, Professor Patrick Kesudian, sir, to give a final remarks on today's proceedings.
my young friends. I'm really thrilled and excited to find that the quarterly meeting of the Hair Research Society has been resurrected, revived after a lapse of some years, mostly because of the COVID thing. I stopped practicing face-to-face as soon as the COVID started, and I was only sticking to online consultations, and that considerably brought down the number of patients I see per day. But one good thing about it was I was able to maintain good records of those few cases that I saw and then follow them up better. And it also helped me to work out some statistics. So at the end of the epidemic, when I looked at my notes, I was surprised to find that almost 10% of those patients involved some complaints about the hair, showing how important trichology is for the dermatologist. I started losing hair in my 40s, and in no way did I find it disadvantageous to my life on this planet. So I just couldn't work up an empathy with people who came to me mourning I'm losing my hair. Also, when I started practice in the 60s, we had very few options, very limited options for treating hair diseases. We, as I mentioned at the Dubai conference a few days ago, gave multivitamins, iron, B complex, and a mild stimulant, whatever that may be. My chief's favorite used to be lactic acid. That's about all. But today, young the trichologists have a wide repertoire of medicines for hair disorders, all based on sound scientific principles. And today's meeting is mainly on such basic sciences drugs. And as somebody said once, the basic science of today becomes the bedside medicine of tomorrow. And we had examples of these two today. We had Dr. Divakar talking to us about basic sciences with reference to the JAK inhibitors. And we had Ravi showing us the bedside results of application of this basic sciences. So you see, it's all nice to have these new drugs, but you must remember that JAK inhibitors are immunosuppressants, as it was pointed out by Deva. And the possibility is when you give it for a long time, you have to be very, very careful, not just for a week or so. You followed up these cases for over a period of years to make sure that you are not disturbing the physiology of the patient in any way. And whenever we meddle with the cell at the molecular level, we are meddling with the unknown. We do not know what that is going to do months later. And he said, query, both of them said, Ravi and Deva, query malignancy is a possibility. We don't know whether we are disturbing the cell in such a way that it lies dormant and then becomes a cancer cell after some years or decades, or whether it causes some genetic mutations which may be passed on to subsequent generations. And all this we have to keep in mind when we are dealing with it. I'm sorry to be a wet blanket or to be a prophet of doom like Jeremiah in the Bible. But then, as clinicians looking after patients' health, let's never forget what the father of medicine, Hippocrates, taught us. Primum non nocere. Firstly, do no harm. I'm very happy that Murugasundaram has once again revived this, and I do hope that this month quarterly meetings will go on until we once again have our international conference of trichology as of yore, and that it will popularize the subject of trichology, because I'm out of it now. And we also thank the various pharmaceutical companies who have come on board to help us with these quarterly meetings. And thank all of you in spite of the IPL meetings. One important person missing is Janaki. I'm sure she'll be watching the IPL at home. A lot of people have missed it because of the IPL. But It had to be preponed because of Dr. Divakar's visit here. Hopefully next time it won't clash with any of these important things. Those of you who have come here newly, as Murug said, you please join the Trachological Society of India and have the benefits of all the journals and other things. Thank you all.
Thank you, sir. Thank you very much for your guidance and advice. Hopefully, we will going to meet all the targets you are set for Hair Research Society.
Ravi, before the vote of thanks, let me talk about the minoxidil finasteride. We all know that androgenetic alopecia is a very common condition, and now we have the combination of minoxidil and finasteride. Previously it was thought that you cannot combine two drugs. It was used as topical minoxidil and oral finasteride. Oral finasteride in a dosage of 1 milligram in men and 5 milligram in women, with 2% minoxidil in women and 5% minoxidil in men, that had a synergistic action. It was found very useful, and we still use that way. But now the finasteride has come as a topical preparation, and many companies, pharmaceutical companies, have formulated that, and they have brought that. And we also find that it is useful for the maintenance of treatment, because minoxidil is very useful in the vertex regrowth, and finasteride is very useful in the occipital, the pre-occipital area or the vertico-occipital area regrowth. And now there are many studies stating that the topical finasteride is equally as effective as oral finasteride. Since finasteride has got a lot of feared adverse effects, because finasteride does not have any adverse effect, but the most of the adverse effects are usually feared. Like people read the literature and they think that it could create impotence and all that. But it does not lead to impotence. What it does is only reduces the ejaculatory volume by 0.03%. There is no impotence or sexual dysfunction with 1 milligram of oral finasteride. But in spite of that, when it is used topically, even that kind of feared adverse effect is not there. And minoxidil finasteride combination has come to have a strong stay in the therapeutic armamentarium of trichology, especially treating androgenetic alopecia. Dr. Reddy's lab, as the pioneers of minoxidil preparation in India, have come out with minoxidil and finasteride. As Chief said, when we started this hair practice, only 2% minoxidil from Reddy's was available. Now we have many formulations, and the vehicle, the minoxidil vehicle, is also improved a lot, because most of the adverse effects are due to the propylene glycol vehicle base, the alcohol base. Now the alcohol base has been reduced, and aqua base formulations have come, and so that's about the combination of minoxidil and finasteride. So that's a useful tool for us. Thank you.
Thank you, Murix, for updating on this. And I am the example for using this topical minoxidil and finasteride about 10 years, when it started. So when I was telling that it's topical itself is very useful, I started getting dense hairs. Prior to that, I was using, as you said, 2% and 5% minoxidil alone. Adding to finasteride, so I started getting dense hairs. So nobody believed that still you have to take oral finasteride. I didn't go for it. Thank you for updating, and I agree with your arguments. Thank you. Now I request Dr. Rashik.
This is to introduce Dr. Rajsekhar. He is not a biological dermatologist. I'll call him a surrogate dermatologist. Because basically he's done his radiology and he's done his clinical pathology. But somehow he has been associated with dermatology from the time he was a student. He used to attend my class, Professor Tambia's class, when he was a third year, fourth year medical student. And throughout he has been associated with us. He has taken us around the world, I'll say. A Europe tour, about 12 countries we went, and he was the one who organized. And again, when we went to Australia, he came with us. Malaysia, he came with us. So many places. And you'll find him at every dermatology meet or trichology meet. And when once we went to Holy Land for a conference in Jerusalem, it was a trichology conference. It was very nice, and all this was beautifully organized by Rajsekhar. So he's part and parcel of the dermatology group, and he's one, call him my protege surrogate dermatologist. So over to you. Thank you.
So good evening, dear friends. It's an honor for me to stand in front of our professor. Sir, we want to thank all the speakers, Dr. Paul Estudiant Divakar, Dr. Ravi Chandran, Dr. Murugasundaram, and Dr. Ravi for invocation, and all the senior professors. All the founder member of Hair Research Society is here, Dr. Sharveshwari, Professor Sampath Kumar. They are all my friends and well-wishers, and they also supported me as their own colleague and friend. So I don't want to take much of your time. We thank our Murugasundaram, a dynamic secretary, and dynamic, and Mrs. Mullai, and Madam Nirmala Patrick Estudiant Madam is also at the back supporting chief, and Divakar wife is also supporting Divakar, and Divakar has donated his time to from all the way from Great Britain. He has visited us, and he has been imparting his knowledge and is bridging the gap. What advance is in Great Britain, he is bringing it very fast to us. So we are bridging the gap fast. We thank you, Divakar, for all the academic thing you are bringing fast to us. And you are in front of your dad, you are doing so much. So our generation should also learn from how your family is contributing to science, to the medical science. So we thank our holy God for this nice evening, and we thank each one of you, and we all welcome you for a cocktail and dinner. And as Murugasundaram told, you all new postgraduates, our Professor Tambayan, Professor Patrick Sarvil said, you are the future custodians. So you all join our society, and we'll be very happy to support all of you. Thank you very much. Good night.
So let us join for cocktails and dinner. IPL. And we are also streaming IPL finals on the big screen.
I request Rajsekhar to hand over the bouquet to Chief.